Hi, my name is Jackie Glover, and I'm a philosopher ethicist at the University of Colorado Anschutz Medical Campus. I'm a professor in the Department of Pediatrics and at the Center for Bioethics and Humanities. I'm the Associate Director for Clinical Ethics at the Center. I co-direct the Ethics Consult Service at the University of Colorado Hospital and am an Ethics Consult Lead at the Children's Hospital, Colorado. I convene our group of clinical ethicists to work on quality improvement and research efforts in clinical ethics consultation. So after this session, learners should be able to describe the differences between morality and ethics, identify 3 methods for ethics case analysis, describe the 8-step method of ethics case analysis that we use here at the University of Colorado with our students, and apply this method to a geriatric case, and also finally identify local ethics resources. So what is the difference between morality and ethics? Most people use them interchangeably, and I do when I'm being lazy. But there is a classic difference that may be important to be aware of when discussing cases. Morality refers to your personal moral beliefs that you get from the important people in your life, like your family, friends, community. It could come from faith traditions. Ethics refers to the intentional and critical analysis of your moral choices. Both are necessary. Health professionals must have skills to identify when they have ethical issues and a process to reason through them. But why? Why not simply rely on your personal moral beliefs? Well, because your personal values may be in tension with your professional values. There can be tensions among your personal values or among your professional values. Your personal and professional values may be in tension with patients' values. You need a way to reason through these tensions. So there are 3 methods of case analysis that are widely cited in the literature. Each shares some key features and has some advantages and disadvantages. I leave it up to you to consider what you think are advantages and disadvantages. These 3 methods include first the 4 boxes method from the University of Washington. We'll talk about the cases method with the VA, and finally the 8-step method that we use at the University of Colorado. The 4-box method consists of the following 4 boxes. And I have colleagues that literally bring a sheet with the 4 boxes on them to take notes during consultations. And this particular colleague adds a 5th box in the center to summarize goals of care and make them clearly visible. Take a look at the tool yourself at the URL provided in the resources. So in the upper left box is the medical indications, and those are based on beneficence and non-maleficence. And so you consider questions like, what's the patient's medical problem? Is it acute, chronic, critical, reversible, emergent, terminal? What are the goals of treatment? From the provider's perspectives, in what circumstances may the medical treatments not be indicated? What are the probabilities of success of the various treatment options? In sum, how can this patient be benefited by medical and nursing care, and how can harm be avoided? In the upper right-hand corner is patient preferences. Has the patient been informed of the benefits, risks? Do they understand? Have they given consent? Is the patient even capable or legally competent? Is there evidence of incapacity? If the patient is medically capable, what are their preferences about treatment? If the patient lacks capacity, has the patient expressed prior preferences? Who is the appropriate surrogate or legally authorized representative to make decisions? Is the patient unwilling or unable to cooperate with the treatment, and if so, why? In the lower left is quality of life, very important. What are the prospects with or without treatment for a return to normal life? And what physical, mental, social deficits might the patient experience, even if the treatment succeeds? On what grounds can anyone judge that some quality of life would be undesirable for a patient, and who cannot make or express such a judgment? Are there biases that might prejudice the provider's evaluation of the patient's quality of life? What ethical issues arise concerning improving or enhancing a patient's quality of life? Do these assessments raise any questions regarding changes, such as foregoing the treatments? What are the plans and rationale to forego treatment? What is the legal and ethical status of suicide? And we would change that language in Colorado to medical aid in dying, and not suicide for some important reasons. So in the lower right is what they call contextual features. These are the justice and fairness considerations about conflicts of interest, and who are the parties, what are limits imposed by patient confidentiality, financial factors, allocation factors, religious issues, legal issues, are there considerations of clinical research and education, and public health and safety considerations. Are there conflicts of interest within the institution that may affect decision-making? And so the cases approach is the second method, and this is the VAs. And really it's an interesting method that combines the process of ethical consultation with ethics case analysis. And so this is the cases approach. C stands for clarify the consultation request. What's the type of consultation? What's establish realistic expectations, get preliminary information, formulate the ethics question. A stands for assemble the relevant information. Consider the types of information that you need, who's the appropriate source for the information, and gather the information systematically and summarize the information with the ethics question. S stands for synthesize the information, determine whether a formal meeting is needed, engage in ethical analysis, which I think is a disadvantage of the cases, identify the ethically appropriate decision maker, facilitate moral deliberation about justifiable options. E is explain the synthesis, communicate with key participants, provide additional resources, document the consultation in the electronic health record and also in the consultation records. And the final S refers to support the consultation process. Follow up with the participants, evaluate the consultation, adjust the process, and identify any underlying systems issues. Now let's discuss the 8-step process that's used at the University of Colorado with our students. We think the advantages of these 8 steps is that they are linear and walk someone through the things that they should consider step by step, and each step builds on the others. This method doesn't privilege any one stakeholder, like physicians and the medical indications, or patients and their preferences. Other stakeholders count, too, like other healthcare professionals, families, institutions, and communities. The ethical analysis consists of identifying all the stakeholders, describing their values, and looking for where they overlap or are in tension. Options are identified, a choice is made, and justified. Then attention is paid to whether and how this issue could have been prevented in the future. So let's get started. Step 1, identify the ethical questions. There are a lot of should questions out there. What should you do medically? What should you do legally? But these ethical questions are the shoulds that represent stakeholder values. Who should make this decision? What decision should be made? What is your initial gut reaction? That's step 2, and this is really important because it forces you to surface the attitudes, biases, expectations, experiences that you are bringing to the analysis. This is important because otherwise you risk rationalizing your personal beliefs and gut reactions. You may ultimately end up in the same place, but you will know why that is, and you will have set your gut reactions aside and developed a clear analysis that you can explain in dialogue with others. Step 3, good ethical analysis begins with good facts. What do you already know? What facts do you need to gather? It is tempting to say, I don't know enough to analyze this case, but you will never know all the facts. Practice what facts that you have and think about what is missing and why that information would make a difference in your analysis. What facts are the ethical tipping points? For example, knowing the patient's advance directive can make the difference between pursuing surgery and not. Step 4 is the very heart of the 8-step process. Who are all the stakeholders? What are their values? And that not explicitly stated values necessarily, but what are the values that you can assume from the point of analysis? For example, even if an elderly patient does not explicitly say this, it can be assumed that the patient has an interest in promoting his or her well-being and reducing harms. Analysis begins with identifying the overlaps in the values and the tensions. Step 5, what are the options in answering the ethical question or questions? Be creative. This is brainstorming. It is rare that there is only one ethical answer. It's usually a range of choices, with some being outside the range of ethical justification. What's your choice? And step 7 is also the most important step with step 4. What justifies your choice? Refer back to your stakeholder values. Your choice can be justified by appeal to the overlapping values or appeal to the most important values. Anticipate objections to your choice and respond to them or change your choice. Appeals to professional codes of ethics, guidelines, literature are also important. Step 8, could this ethical pickle have been prevented? Why or why not? What are some systematic changes or systemic changes that you could make to address the ethical questions? So now let's apply these 8 steps to a case analysis, the story of Susan Martinez.